Antibiotics. Amoxicillin. Coverage is gram-positive. Streptococcus, non-beta lactamase producing Staphylococcus aureus, Listeria, Enterococcus. Fair for gram-negative. Shigella, ampicillin, E. coli H. fluenzae, non-beta lactamase, Proteus mirabilis in gonorrhea, Pasteurella multocida. Rash, diarrhea. The next one is the beta-lactamase inhibitor. Coverage against beta-lactamase producing bugs and B. Fragilis Haemophilus influenzae, Proteus, Klebsiella, E. coli, Moraxella catarrhalis, in gonorrhea, Staphylococcus aureus. Bactericides, Frag, anaerobic. Clindamycin. Coverage is gram-positive Streptococcus, Staphylococcus, MSSA only, acnes, anaerobes, atypicals, rash, diarrhea, pseudomembranous colitis, increase AST and ALT, thrombocytopenia, granulocytopenia. U.S. box warning can cause severe and possibly fatal colitis. Should be reserved for serious infections where less toxic antimicrobial agents are inappropriate. It should not be used in patients with non-bacterial infections, such as most upper respiratory tract infections. Hypertoxin-producing strains of C. difficile cause increased morbidity and mortality, as these infections can be refractory to antimicrobial therapy and may require colectomy. C. difficile associated diarrhea must be considered in all patients who present with diarrhea following antibiotic use. CDAD has been observed greater than 2 months post-antibiotic treatment. If CDAD is suspected or confirmed, ongoing antibiotic use not directed against C. difficile may need to be discontinued. Institute appropriate fluid and electrolyte management, protein supplementation, and surgical evaluation as clinically indicated. Patients with CDAD may have mild, moderate, or severe dehydration with possible electrolyte disorders such as hypokalemia. Oral or parenteral fluid replacement and electrolyte replacement should be instituted as needed. Antibiotic treatment for mild CDAD includes either oral metronidazole, 30 milligrams per kilogram, or 250 milligrams POQID, or 500 milligrams POTID, or 30 milligrams per kilogram POQID. Max is 500 milligrams per dose, or oral vancomycin, 40 milligrams per kilogram, or 125 milligrams POQID. Max is 125 milligrams per dose for 10 to 14 days. Note, this is the only indication for oral vancomycin, which is CDAD. Symptoms should improve in 2 to 3 days, although diarrhea may persist for 7 to 10 days. Stool cultures may remain positive for 6 weeks after successful treatment. Anti-motility agents are currently not recommended in children or adults due to the risk of toxic megacolon. Probiotics are currently not recommended in the treatment of CDAD. Tetracyclines, including doxycycline. Coverage, wide range of gram-positive CA-MRSA and gram-negative coverage with high degree of resistance, anaerobic coverage, atypical coverage. GI, photosensitivity, tooth discoloration in peds, dizziness. DIs related mostly to binding, chelation with multivalent cations. Separate administration 2 hours before or after. Quinolones. Coverage available agents have varying degrees of gram-positive, gram-negative, and anaerobic coverage depending on the generation. GI, rash, photosensitivity, QT prolongation, levo, moxifloxacin, arthropathy, tendon rupture, peds and elderly. DIs, chelation with multivalent cations, alter, theophylline and digoxin plus warfarin is increased bleeding. Macrolides can be thought of as alternative to penicillins. Coverage, gram-positive coverage, S. pneumoniae, S. pyogenes, Staphylococci, S. aureus, not MRSA, Clostridium perfringens. Gram-negative coverage, generally poor, some H. influenzae, some miscellaneous coverage, Mycoplasma, Legionella, Chlamydia, GI cholelithiasis, QT prolongation. Sulfonamides, gram-positive streptococci, staphylococci negative, including MRSA, CA MRSA, gram-negative E. coli, Haemophilus, Klebsiella, Protease, Shigella. Others, Nocardia, Chlamydia trachomatis, pneumocystitis carini, rash, fever, nausea, vomiting, diarrhea, hemolytic disturbances, crystalluria, bone marrow suppression, caution in late pregnancy and newborns.